Good afternoon, everyone, and welcome to the last session of the day of this very special and very important European Pancreatic Club virtually from Kiev. Before to start the session, I would like really personally thanks the European Pancreatic Club, but mostly the local organizing committee for inviting me to chair this session. And I think I can say that on behalf of all the EPC family, that I would like that every one of you joining this moment live to this event to raise a big applause to all our Ukraine colleagues, women and men, that did something no one did before, organizing an amazing, incredible meeting in extremely difficult condition. We are sure we will be there in person soon, and thank you again very much for what you are doing. Saying that, I will start with the first speaker of our session today, Dr. Zemskov. I hope I pronounce your name correctly, that will speak about radiotherapy in combined treatment of pancreatic cancer. Thank you.
Hello, ladies and gentlemen. My name is Sergei Zemskov. I represent Bogomolets National Medical University, Kiev, Ukraine, and my speech is about radiotherapy in combined treatment of pancreatic cancer. So what we know about radiotherapy in pancreatic cancer is that history is about 40 years, at least what we can see in literature. It was first used to alleviate the pain, and now it's widespread in use to shrink the tumors and increase survival. National Comprehensive Cancer Network claims that it is the standard clinical practice for locally advanced pancreatic cancer, and the American Society for Therapeutic Radiology and Oncology believes that it becomes even more important these days as new systemic therapy develops. Radiotherapy can be applied in adjuvant therapy, in neoadjuvant therapy, and in definitive therapy of pancreatic cancer. Both technical regimes are used today, stereotactic body radiotherapy and conventionally fractionated therapy. But there are still a lot of questions and no consensus concerning dose fractionation, sequencing of chemo and radiotherapy, indications of palliation, and others. Short information about the difference of technical approaches, stereotactic body radiotherapy versus conventional therapy. The main difference is the fractionation. In SBRT, short fractionation is used. It's 1 to 5 fractions. So the whole therapy durates about 1 week versus 25 to 35 fractions and corresponding 6 to 8 weeks in conventional therapy. There is a strict motion control and daily image guidance in SBRT versus variable motion control, if any, and at least 1 week of image guidance in conventional radiotherapy. Large ablative dose is done daily in SBRT, and small doses during a long period of time is obtained by the patients in conventional radiotherapy. In year 2019, ASTRO has published the recommendations for indications for both conventionally and stereotactic body therapy in different settings of pancreatic cancer. But as you see, the quality of evidence is still low, so today there is no strong consensus in these questions. Recent systemic review has brought us an information about the clinical difference of SBRT and conventional radiotherapy. We know that SBRT appears to be more effective in increasing the overall survival, at least in 2 years, and it is more toxic, up to 80% of grade 3 and 4 toxicity versus 38% in conventional radiotherapy, in settings of definitive therapy in locally advanced pancreatic cancer. Now, coming to our results, we had a study, collaboration study between our university and Ramadanov Neurosurgery Institute, both located in Kiev. 67 locally advanced pancreatic cancer patients were in this study. Linac trilogy machine was used, and radiotherapy was divided into 12 fractions, 3 gray per fraction. All patients were biopsied and verified as pancreatic ductal adenocarcinoma. They had biliary decompression when needed and gastroenterostomy. They all underwent 3 cycles of induction gemcitabine-based chemotherapy. Afterwards, the radiology control was done, and if no metastatic disease was seen, they were further subdivided into 2 groups. The main group continued the same chemo with radiotherapy, and the control group continued just the same chemotherapy. As a result, in 1 year, we saw the trend to increase overall survival in patients with radiotherapy. It was 90% versus 53% in no radiotherapy group. The progression-free survival was 16 months in combined radiochemotherapy versus 11 months in the chemotherapy group. Local control of the tumor was 84 versus 22. No grade 3 or 4 adverse events were detected, and pancreatic pain score evaluated by AORTC scale was significantly lower in patients with chemoradiotherapy. Progression-free survival was significantly higher in patients with chemoradio versus chemotherapy alone, and you see the scans. Patient 1 year after chemoradio, he actually has met the criteria for resection, but refused and survived for 3 years in general after the treatment. So what we learned from our study is that addition of radiotherapy to systemic therapy in locally advanced pancreatic cancer is beneficial in terms of local control, level of pancreatic pain, and progression-free survival, with no evidence of inappropriate toxicity. Hypofractionation of radiotherapy makes it shorter, and it's very useful in time of war and time of pandemics because of clinical facility overload. In the second part of my presentation, I would like to give a short review about neoadjuvant therapy, radiotherapy in neoadjuvant settings. We know that neoadjuvant therapy is usually better compliance than adjuvant. We treated to select patients with better prognosis. We treat the putative micrometastatic disease, which is not seen at primary radiological examination. And we give the higher probability of achieving R0 resection and nodal down stages. There are 2 very interesting publications of this year that I would like to pay attention. The first one is from the Dutch study, PREOPANC trial. This is the second publication of their results. The first one did not manage to show the benefit of overall survival in patients with radiotherapy versus patients without radiotherapy. There was a significant difference in R0 resections, 71% versus 40% in those who was irradiated versus patients without radiotherapy. But the latest publication shows that 5-year overall survival was 20% versus 6%, and this is significant. And this publication shows that neoadjuvant chemoradiotherapy is really beneficial for patients with potentially resectable and borderline resectable pancreatic cancer, if compared with surgery upfront and usual adjuvant therapy. The weak point of the study is that chemo regime was gemcitabine. It was planned in pre-FOLFIRINOX era, but still the role of radiotherapy clear in this setting. Another interesting publication is a cross-validation study of National Cancer Database of United States and German Cancer Registry. This is the real-world study, which is always very interesting, and the main points of it is that patients with resectable pancreatic cancer has mostly benefited from the adjuvant therapy plus surgery, neoadjuvant therapy plus surgery plus adjuvant therapy, so-called sandwich approach, when compared to neoadjuvant plus surgery or surgery plus adjuvant. So this is another point which would be interesting and which may allow us to talk not about neoadjuvant or adjuvant, but about perioperative systemic or chemoradiotherapy in patients with pancreatic cancer. We have a lot of evidence of efficacy of radiotherapy in neoadjuvant settings. As for surgeons, it's quite clear that neoadjuvant chemoradiotherapy, as well as just chemotherapy, reduces the risks of postoperative fistula, which is the main, the hardest and the most scary complication, postoperative complication in pancreatic surgery. It also pays no negative effect on postoperative complications and mortality. So what could be the reason for such effect? The reason is pancreatic fibrosis. Both radiotherapy and chemotherapy causes the local fibrotic changes in pancreas, lobular atrophy and loss of pancreatic acini, which we see at morphology of the patients, which really decreases the probability of postoperative pancreatic fistula. So, what is the role of irradiation in combined therapy? The majority of randomized studies recognize that neoadjuvant chemoradiotherapy with conventional chemoradiation improves local control and R0 resection rate. Whether RT itself within neoadjuvant chemoradiotherapy contributes to overall survival is still unknown. It's still questionable. Some studies present controversial results in terms of clinical relevance of irradiation. However, ASTRO recommendations claim that high level of consensus on appropriateness of neoadjuvant SBRT or conventional radiotherapy in patients with resectable pancreatic cancer. Neoadjuvant regimens of systemic chemo followed by SBRT is conditionally recommended for neoadjuvant therapy within consensus of 77%. The SBRT technique is getting more popular because shorter duration of treatment and actually the same toxicity and may be better oncological effect. Take-home message. The combination of radiotherapy with systemic therapy in locally advanced pancreatic cancer can be safe and more effective in terms of local control, management of pancreatic pain, and progression-free survival. In neoadjuvant therapy for borderline resectable and potentially resectable pancreatic cancer, it decreases the rate of postoperative fistula, increases R0 resection rate and rate of patients with negative lymph nodes, perineural and venous invasion, as well as time to recurrence, and may increase overall survival. Neoadjuvant SBRT after multi-agent induction chemotherapy may be the future trend in neoadjuvant treatment of pancreatic cancer. Sandwich approach, neoadjuvant plus surgery plus adjuvant setting appears to be the most beneficial in terms of overall survival of these patients. Thank you for your attention.
Thank you very much for this great lecture. I have actually several questions for you, but I would like to open the discussion to the participants. So please, you can write in the chat. Violation of the microRNA profile affect the expression of oncogene and suppressor gene. What is your attitude towards this theory? Is there any new information about this? That's the first question.
Okay, you mean the question concerning response for radiotherapy, or what's the point of this molecular biological markers in this context?
Hey, can we ask Professor Krivoshko if he can formulate the question differently at the same time? I start with my question, if you don't mind.
Yeah.
So the first is a comment. So I personally disagree that PREOPANC study show any role of radiation therapy. In fact, the other arm was upfront surgery. It should be chemo without radiation and one with radiation and chemo, and then you could compare if there is a role, because my objection can be that chemo is the one giving advantage. Now, the reality is another one, I think. The only really prospective randomized trial designed correctly has been the Alliance trial. The Alliance trial, the results are published in ASCO last year from an international American consortium, compared in neoadjuvant setting FOLFIRINOX and radiation versus FOLFIRINOX alone as neoadjuvant treatment. And actually the study was closed before the end for inferiority of the group with radiation therapy. So the real only well-done prospective randomized trial so far show an inferiority of radiation therapy. So I would like to have a comment on that.
The thing is that it depends on the type and regime of radiotherapy.
That was all SBRT, only SBRT.
What were the doses? You know, because
I don't remember. I think we're the one that you show. So you know, but the reality is that it's not that they were the same. It was inferior significantly, so they couldn't finish the study because was so bad, the group with radiation, that they need to stop the study before the end.
Probably because of side effects.
Well, the survival was much lower. I think was like half of the patient that didn't receive radiation. If you want, I can give you also the exact numbers. I mean, I think it will not be difficult to find, but beside that, this is not really the point. The point is that, I mean, I don't know if, you know, if that's, I mean, can be by you somehow commented or something like this, because that's, I think it changed it completely. So now, for example, in US, where I think the majority of centers use it, chemoradiation in neoadjuvant setting, many centers now start to be very, you know, concerning in using chemoradiation for patients with pancreatic cancer because of those results.
This is the point of regimes of SBRT, because we still have no consensus, and a lot of centers have their own approaches. They try it and they publish their results. it can be really toxic, as you have seen. Some studies show toxicity up to 80%. So it really depends on what are the doses. So what is the fractionation, and another point is when to use it and how to combine it with the surgery. So there are still more questions than answers in this point, but I believe that it should be further investigated. We still have no good data about radiosensitivity of different type of tumors. We have some data about chemosensitivity, some markers, but we still don't know anything about radiosensitivity. But we know that different patients can react completely different with the same doses and the same in the same type of histology. So there are still a lot of questions, and as I said, no consensus.
Okay, just to mention the number that you asked me before. So the overall survival of the arm without radiation was 31 months. The one with radiation was 17 months. In these preliminary results published in ASCO last year from the Alliance trial. Any other question from the chat? Okay, I have another question for you. And, you mentioned the problem of reduction in surgical complication. In fact, again, during the ASCO presentation, the Alliance trial, the group of radiation was associated with the increased mortality compared to the group without radiation. And recently, our group published results from the National Cancer Database showing also there, basically double mortality in the group who underwent radiation as a neoadjuvant setting versus the group that didn't receive. So I would like to have a comment about that.
So basically, because of pancreatic fistula, the complication rate due to pancreatic fistula. So this is...
Yeah, probably that's lower can be, I agree with you, but the mortality, post-operative mortality, either in Alliance trial and in this retrospective analysis on the National Cancer Database I mentioned, were higher in the group that received radiation. Could have been related to bleedings, related maybe to arteritis caused by radiation therapy?
Yeah, probably it can be the reason for vasculitis or mucositis, postoperative mucositis in these situations.
Okay. Let's see if there are any other questions from the audience. No. So I really want to thank you very much, Professor Zemskov, for this very, very enlightening review of the current status. And I agree with you, very, very little defined status of the role of radiation therapy in the treatment of pancreatic cancer, very debated. And I will then give the podium to a giant of pancreatic surgery, for me, actually a lighthouse during the first phase of my career, because he has been a person that really strongly supported my my growth, especially inside the EPC. So we discussed about mortality related or not related to radiation therapy, or potential benefit of radiation therapy in mitigating some of the severe complications of pancreatic surgery. And Professor Helmut Fries will speak about major complication after pancreatic surgery. Professor Fries, when you're ready.
Dear colleagues and friends, first of all, I would like to thank Professor Natalia Gubokritz for her kind invitation to participate in this year EPC meeting. Dear Natalia, we both have tried for more than 10 years to get the EPC meeting to the Ukraine, and I'm very sad that this year meeting cannot take place in person. I will talk about advances in pancreatic surgery, and I would like to address acute and chronic pancreatitis as well as some aspects in pancreatic cancer surgery. The first message I would like to give you is that pancreas disease is strongly increasing. And this comes from epidemiological data in acute and chronic pancreatitis as well as pancreatic cancer. And especially for pancreatic adenocarcinomas, the number of cases over the last 15 years, for example, in the United States, has increased by almost 80%. So this means we as pancreatologists will have a much higher caseload of patients in our hospitals in the upcoming years. In acute pancreatitis, surgery is clearly on the retreat. And this is related because the indication of and the type of intervention in the management, especially in necrotizing pancreatitis, has completely changed. 30 years ago, most patients with necrotizing pancreatitis were treated by open surgery. Nowadays, in these patients, first a drainage is placed, and if this is not sufficient, minimal invasive surgical necrosectomy is successfully used. Only in a few cases, open surgery is still needed. However, minimal invasive surgical necrosectomy is challenged by endoscopic necrosectomy, and a number of prospective randomized trials have shown that the endoscopic necrosectomy approach is equivalent to the surgical minimal invasive necrosectomy strategy. So in acute pancreatitis, surgery is on the retreat. However, in chronic pancreatitis, the role of surgery is strongly increasing. We have very clear indications when patients with chronic pancreatitis should be operated. This includes the pain, syndrome, stenosis of the duodenum, common bile duct, main pancreatic duct, or when portal vein compression occurs. There was a lot of controversy in the past years whether endoscopy or surgical approaches should be applied in complicated chronic pancreatitis. And I think this controversy is finished by controlled randomized studies with long-term survival up to 5 years, clearly showing that surgery is better than endoscopy in complicated chronic pancreatitis. There is still controversy when is the best time point for surgery in chronic pancreatitis, and also this open question is, in my opinion, clearly answered already by retrospective and also controlled randomized prospective studies, which clearly indicate that early surgery is better than late surgery because it gives a better pain control and also contributes to the preservation of exocrine and endocrine pancreatic function. So if surgery is better than endoscopy in complicated chronic pancreatitis, what is the best operation for patients with chronic pancreatitis? We have a number of operations which can be applied and have to be applied in patients with chronic pancreatitis, and we have to select the type of surgery tailored to the problem of the patients with complicated chronic pancreatitis. And it's demanding for surgeons to do surgery in chronic pancreatitis because they need expertise in all these kind of different surgical procedures to bestly serve their patients with chronic pancreatitis. Now I move to pancreatic cancer, and the biggest problem in pancreatic cancer is still the late diagnosis. Majority of patients, more than 80%, are diagnosed in locally advanced disease or metastatic disease. And if we diagnose patients so-called early in a resectable tumor stage, if we look at the pathology report after resection, it's always in 80% already advanced tumor stages. However, by radical surgical approaches, zero resection rates of up to 40% can nowadays be achieved in these primary resectable pancreatic adenocarcinomas. And resection in combination with adjuvant chemotherapy gives a wonderful long-term survival perspective to these patients with a mean postoperative survival of approximately 54 months. So in surgery for pancreatic adenocarcinomas, two principles applies. One principle means curative resection to do an oncologic radical operation to achieve a R0 resection, and this should be accomplished with minimal postoperative complications, that patients have a perspective for a long-term survival with their disease. However, R0 resection in pancreatic cancer is difficult. You see here only 20% are R0 resected in a big collective of the Heidelberg group, which is a very experienced surgical group in pancreatic cancer surgery. And in their collective in borderline resectable patients, the majority of patients underwent only a so-called R1 resection. And that we can do better in locally advanced and borderline resectable pancreatic cancer is initiated by effective neoadjuvant treatment. And we have learned in the past that by effective neoadjuvant treatment, a high percentage of patients with borderline resectable and locally advanced pancreatic cancer patients can be converted in a resectable stage, and many of these patients undergo a complete R0 resection. And this is nicely demonstrated in also prospective randomized controlled trials, where it was clearly shown that after neoadjuvant treatment in borderline resectable and locally advanced tumors, the R0 resection rate is significantly increased, and also the mean survival of these patients. Therefore, in borderline and locally advanced pancreatic cancer, neoadjuvant treatment is nowadays an established standard. If we want to improve the prognosis of patients with pancreatic cancer, we have to increase surgical radicality, and this means we have to achieve wider surgical resection margins. And of course, our oncological partners have to take care for a better control of systemic disease, which is still the major problem in resected pancreatic cancer patients. So when we want to increase local radicality, should we be more liberal in resecting vessels? This means veins and arteries surrounding the pancreas. In the past, venous infiltration was a contraindication in pancreatic cancer patients. This is overcome in the past because by modern surgical techniques, venous resections can be done normally safely and is often needed to achieve a real R0 resection. We know from meta-analysis that in venous resections still morbidity and mortality is increased, and 5-year survival in these patients is decreased. However, we have learned that this type of operation can be done safely in centers with experience, and therefore venous infiltration should not be longer a contraindication in pancreatic cancer resection. Arterial infiltration was for a long time a very strict contraindication for pancreatic cancer resection. And this was related to the outcome after pancreatic cancer resection in combination with arterial resection, with significantly increased reoperation rates 3 times, higher morbidity 2 times increased, and especially 5 times increased postoperative mortality in these patients. And these higher complicated data were also accompanied by poor long-time survival in these patients. And this is also shown in a newer meta-analysis indicating in arterial resection mortality is significantly increased and also morbidity. And these patients with arterial resection have a higher risk for a worse 3-year survival. However, the authors also state that arterial resection might be an option in patients who will be operated in expert centers. And here are the data coming from a center of expertise from Japan, showing that the number of arterial resection is increasing. It can be done safely with a longer operation time, but comparable complication rates. What comes out of this study is that if a arterial resection is performed by an arterial resection in pancreatic cancer patients, the median survival time is significantly prolonged compared to patients in whom a R1 resection was performed. And it was also very nicely shown in this study that especially neoadjuvant treated patients take advantage from arterial resection because recurrence-free survival and overall survival in neoadjuvant treated patients with arterial resection is significantly longer compared to patients without neoadjuvant therapy and arterial resection. And this is not only true in Asia, this is also true in Europe. These are the data from the Karolinska Institute in Stockholm, where the authors could also show that by arterial resection in selected patients, survival is significantly prolonged compared to palliative treatment. And this was especially true for patients who underwent neoadjuvant therapy. So for arterial resection, it's important to select the right patients. And this comes also out very clearly from the study from Heidelberg, where they have analyzed their cases with arterial resection, and they had 2 treatment strategies: peri-adventitial dissection, which means all the tumor tissue around the arteries is dissected and removed, or a clear, true arterial resection was performed. The first message out of this study is that peri-adventitial dissection is only possible in patients with neoadjuvant chemotherapy. And the data of peri-adventitial dissection is very promising. You see, in comparison to true arterial resection, a 0 rate is higher. Median survival and 5-year survival is significantly longer, and it can be done with an acceptable hospital mortality rate. And also, again, in arterial resection, experience is important to decrease postoperative morbidity and mortality. There is still a strict statement for contraindication for resection in patients with distant metastasis. However, also this statement has to be challenged in the time of neoadjuvant treatment. In this study from Heidelberg, 85 patients with occult liver metastasis were resected, and the authors could clearly show that resection of the primary tumor and the occult metastasis resulted in a median survival of 12 months, which was significantly longer than in patients with palliative treatment. And in their patient collective, they have achieved a 5-year survival rate of 8.1%. I think these are very interesting data, and these data are confirmed by data from Hamburg, where they could also show that if tumor metastases in the liver are detected intraoperatively, survival is prolonged by resection of the primary tumor and the metastasis compared to bypass surgery. Of course, this is highly patient selection. However, it indicates that some patients also with metastatic disease take advantage from resection, and that metastatic disease should not be a contraindication for resection in all patients comes also out of this Italian paper. 127 patients with liver metastasis, they all underwent chemotherapy with a partial remission rate in 1/3 of the patient, and 7% of the patients developed a complete response. And they have selected out of these response patients 11 patients who were selected for surgery with an excellent median survival of 39 months compared to 14 months survival in responders without undergoing tumor resection. So neoadjuvant treatment also in metastatic pancreatic cancer disease offers the chance for long-term survival by surgery. However, we have to select the right patients, which are responders and candidates for resection. Surgery can now be done open, laparoscopic, and robot assisted. All these procedures are available in centers, and we have to select the right patients for each of these individual surgical procedure, depending by which less morbidity, low mortality, fast recovery, and better quality of life for the patients can be achieved. Here's my take-home message for my presentation. In acute pancreatitis, surgery is on the retreat. In chronic pancreatitis, surgery is on the rise. In pancreatic cancer patients, radical surgery can significantly improve the prognosis, and especially neoadjuvant treatment offers new perspective to patients with locally and borderline resectable pancreatic cancer, but also to patients with vascular involvement and with metastatic disease. Many patients can be converted with local advanced disease into resectable disease, and zero resection with prolonged survival can be achieved. And also patients with arterial involvement in metastatic disease, I feel that neoadjuvant treatment gives them a good perspective also for a surgical resection in long time. So in pancreatic cancer and in all other pancreatic disorders, we can improve the prognosis. We will do it if we work together as pancreatologists to help our patients. I thank you for your attention, and I'm happy to take questions.
Thank you very much, Professor Fries, for this really amazing overview on the advances in pancreatic surgery. We have a question from Professor Barbu, and this is: what is it your opinion about neoadjuvant chemo in stage 1 and 2 pancreatic cancer?
Thank you, Marco, for your question, or Sorin Babu for your question. I think you want to address the question whether also resectable pancreatic cancers should be neoadjuvantly treated. There's a lot of speculation whether this is also helpful, but up to now there is no prospective controlled randomized data on this. I think we have to perform studies to see whether patients with neoadjuvant treatment in resectable pancreatic cancers are really doing better than patients who get primary surgery. Up to now, the data of these neoadjuvant treatment studies are not convincing.
Thank you, Professor Fries. And I have also a question for you once I'm waiting for a new question in the chat. So I have a personal opinion, and I would like to know what you think about that. You know, if you look the way traditionally we stage pancreatic cancer has been very different from the way we stage all other kind of cancer. So there has been, if you want, a technical bias on pancreatic cancer, right? I mean, we basically stage on vein, artery, how much, how many degree. That's, if you think carefully, is unique for pancreatic cancer compared to other cancer. And I believe that, you know, that could be, and we can discuss forever about that, justifiable, considering that we didn't have really what is needed for a disease like pancreatic cancer, systemic control. Now that we start to have some systemic control, Is it my impression, or all the, let's say, the cliche, all the, the standard we had before need to be revised? I might just make an example to be sure my question is clear. When I started to be a young resident, when a patient came with the metastatic colorectal cancer, was a palliative patient. Today, I don't want to say all of them are cured, but definitely there are good chance for a long survival. So as much more we control systemically a disease, much more useful it become aggressive, but at the same time, much less important anatomy has in the decision making. Is it your feeling as well, or is it just my feeling?
Sure, Marco. If systemic treatment is improving, and we have still a big lack for systemic treatment in pancreatic adenocarcinomas compared to other malignancies. I think if our therapy would be more effective, I think you would get better treatment effects out in the adjuvant setting as also in the neoadjuvant setting. And in many cancers, neoadjuvant setting is really completely established and standard nowadays. This is still not the case in pancreatic adenocarcinomas, and I think we are happy with FOLFIRINOX. In the adjuvant setting, we get wonderful long-term survival results in R1 and in our zero resected patients. However, also FOLFIRINOX is just a step to where we want to come. I think we reach much more effective systemic therapies. And if I follow up now patients, what we have resected radically, and there the vein and the artery is important. I think there we are also expanding the borders where we go, because 20 years ago, arterial dissection was a clearly no-go. Nowadays, it's a go in the centers, especially if patients had neoadjuvant treatment. So this dogma is also updated, I would say. And if we have more effective systemic therapies, I would think we can solve many more problems in pancreatic cancer patients and improve the survival. The best medical therapy is you apply it to the patient, it has no side effects, and the tumor has disappeared. We are looking forward for this. And at the moment, surgery, in my opinion, is a big player in the treatment of pancreatic adenocarcinomas. And if we could resect more patients with pancreatic adenocarcinomas, prognosis would be much better.
Professor Fries, there are other questions, but I'm pretty well known to be very precise in my session, so I'm going over time. Therefore, I think, that after obviously thanking very, very much both our excellent speaker and also the audience, that even if, still, at least for European time, pretty late, are very numerous listening this very intriguing session. Once again, I want to thank, the organizing local committee in Ukraine to put together an amazing program and succeed wherever was not imaginable any things like this. We are all there in Kiev with our heart. Unfortunately, we cannot be present physically. I'm really sure that soon we're going to happen again. So I really want to thank all the speakers, all the participants, the EPC, and our Ukraine friends for this, again, amazing session of this incredible EPC. Thank you, everyone, and good night.
Thank you.
We agree on this. Thank you. Bye-bye.